Um, with the permission from my uh, coordinators for today's webinar, and on the behalf of Nepali Society of Neurosurgeons, I thank Dr. Aditya Gupta to come here. And without delay, now I will start my present webinar. So the topic I have chosen today is about the neuronavigation. See, the navigation means it's a guidance. It's a guidance. So it's a study that focuses on the control and guidance of a movement from one place to another place. From this first slide picture, you can see the concept of navigation has evolved from the marine world. When the ship and the boats used to travel from place to place, and they used to travel without much guidance. So they thought there should be some kind of guidance which will help them to come out safely from place to another place. So in 11th century, when first time magnetic compass was evolved, it was first time used in the marine world. It was used in the sea, and because only looking at this magnetic device, they used to travel based on the direction of the wind. And in 15th century, mariner's astrolabe was developed. It is from on this basis. The principle is that they used to look at the latitude of the star or moon or the sun and compare with the altitude of the ship over the sea. This is how they used to localize themselves in the sea. In the 18th century, when mariner's compass was developed, it was that time it was believed to be most accurate method of localizing themselves in the sea. And that time it was compulsory in US Navy and in all the compulsory to keep in all the ships and boats. The golden time started when radio direction finding were developed. But this process took many infrastructures, like you have to keep the many radio stations in the different places. And by contacting through the radio, they used to travel from places to places. And a much safer time came in 1940 when radar was developed. In the radar, by just looking at the beep of the light, they used to travel from anywhere. And it was the safest mode of navigate themselves. It was compulsory. And after the invention of radar, aircraft were commercialized to fly. And nowadays, global positioning system, which is based on satellite system. This is actually owned by the United States government. So the things have made so easy. If you remember, even my time when I used to travel abroad, I remember I used to have a paper map in my hands to look for the direction. I used to ask people on the street about the direction. I used to go to the stores to ask the direction. I have seen that time, but now you have a GPS everywhere. Everyone has GPS in their cell phone. And with the help of GPS, you can reach anywhere very adequately. It only does not show you the path. It will also show the time to reach the place and whatever you wanted to know. So similar concept, GPS is a navigation system in neurosurgery as well. So satellite is a localizer device, which is the camera, and the radar is our patient's reference frame, and display is almost similar. So it's almost similar concept. So these are the intraoperative imaging modalities used in neurosurgery. Way back, starting from way back in 1895, when Roentgen developed plain X-ray. And plain X-ray, it was not only used to diagnose the disease, it also helped to plan accordingly. From the looking at the X-ray of the skull, neurosurgeons who diagnose many cases, many diseases like pneumocephalus, any fracture, even looking at the presence of calcifications of the pineal gland, deviation of the calcifications from the X-ray, they used to diagnose the site of the lesion. Similar thing, ventriculography. When Dandy cannulated the ventricle, he used the contrast. This is how they used to localize the diseases, to localize the mass effect areas. Egas Moniz in 1927, when he developed cerebral angiogram, after them again looking at the angiogram, they used to diagnose, not only to diagnose the disease, but also to plan accordingly. Ultrasonography was developed in 1970. See, but it is still not widely used because of its little bit drawbacks. But I think this is one of the very nice device which can be used in neurosurgery. Though we have only ultrasonograph, which gives two-dimensional images, but and because two images, you cannot clearly see the margins of the tumor, like, or for deep-seated small lesions, you know, it's some troublesome. But if you have 3D ultrasonography, definitely it is not lesser than intraop CT scan or MRI. Golden time in neurosurgery, it started after invention of CT scan by Onspel in 1973 and MR imaging by Paul in 1973. After this time, neurosurgery totally changed, and then developed PET and SPECT, and so many, like in MRI, different type of images were developed. So despite all these intraoperative localizing tools, people were still not happy. They wanted something more accurate, reason why they developed image-guided navigation. This is one of the example of pneumoencephalogram. By looking at this X-ray, in that time they used to localize the lesion. It is ventriculography by Dandy. You can see the Dandy's cannula inside the ventricle in the contrast. So from X-ray to the neuronavigation, where today we are, the difference is almost 125 years. It took 125 years to reach us here. And the history of neuronavigation is about 20 years only. So what we are today, it's not built in few days a year. It's because of the work, experience, dedication from our ancestors, from learning from the past. They look at the scenario, what used to happen in the past. In the past, they used to cut and see, like exploratory laparotomy, exploratory boreholes, and also by doing such procedures, they used to find the lesion, they used to localize the lesion. And even today, what is there is seeing the surface. You look the images and you preserve those images inside your brain. And you use that brain your thinking thought process in the surgery. Okay. Now, what is utmost is now it's you see through the surface is neuronavigation. So you don't only rely on neuro images. You in the real time by putting your tip of one instrument, you can clearly see the lesion, localize the lesion. So this is what neuronavigation system is. It is the set of computer-assisted technology which is used in neurosurgery by neurosurgeons to guide or navigate within the confines of the skull or vertebral column during the surgery. Principle of neuronavigation system. Principle of neuronavigation system is best to tell you where exact the tumor is. Second, how to reach your target safely. And third is to let you know where you are working. So if you know all this prior to your surgery and during the surgery, I mean, this is the safest thing for you and confidence for yourself, safety for the patient. So this neuronavigation, actually, it is based on the principle of stereotaxy. And stereotaxy means it's three-dimensional arrangement or order. So image-guided surgery is an operative technique by which correlation between imaging studies and the operative field is provided. Stereotactic surgery is never new. You know, stereotactic surgery was started around 80, 90 years ago. So 80, 90 years ago, they used to do a lot of stereotactic surgery for psychogenic and functional neurosurgery. It was very famous that time. But after the levodopa come into the market, role of stereotactic surgery almost died, almost vanished. That time only non-stereotactic functional neurosurgery in the form of dorsal column stimulation were only done. But again, after the invention of CT scan and MRI during the mid of the 70s, again, stereotactic neurosurgery revived. And now you see stereotactic surgery by using VRW frame or CRW frame or Lexil. It's so much popularized and it is being used all over the world very widely. It was Horsley and Clark who first made this stereotactic frame, but it was applied in animal model only. The drawback of this frame was that it was not flexible, it was not adjustable, it was fixed for certain kind of animal only. So in 1947, Spicer and Voices first time developed stereotactic frame in human. And later in 1948, Lexel developed first arc-centered frame, and gradually, in between this time, many type of stereotactic frame were developed. You know, like by Taleric, who is a Japanese neurosurgeon, he also developed a frame which was very popular at that time. So you can see different kind of frame. Some disturbance. Can someone mute all? Dr. Amit, can you mute all? I see
Dr. Rajiv, I'm not the host right now, so I cannot manipulate it there.
So different kind of frame were developed, like by Japanese, by Lexel, by Kokors, many types. So there were proliferation of stereotactic frames. So these are all frame-based stereotaxy. There were drawback of frame-based stereotaxy, and to overcome this, frameless stereotaxy was developed, and the first frameless stereotactic system was developed by David Roberts and Associates in 1986. And the good thing about the frameless stereotaxy is you don't need to keep the patient head fixed. You can tilt the head during the surgery. Perhaps easier. So the advantage of a frameless system was the ability to track a surgical instrument or probe in a real time and projects its position onto the preoperative CT scan or magnetic images. These are the essential components of a neuronavigation system. One is a navigation system with a monitor. You see there where it comes with camera. And second is imaging data which displays in the monitor. And another is patient reference. This is the patient's reference arch, which just close to the patient's head. So they are different for optical and electromagnetic navigation system. And then different specialized instruments. Now, fiducials has got very important role in neuronavigation because this is the real marker where you localize how you localize the lesion. But I mean, it is advised always to use fiducials in all the cases. Fiducials has to be kept from before the surgery, prior to imaging acquisition, until surgery complete of the surgery. But like there are conditions like electromagnetic neuronavigation system, and you can do without the use of fiducials. So fiducials is the Latin word, it means trust. So it almost, if you have fiducials in the cranium, chances of error are very less. So navigation is based upon targeting relative to known reference points. There are different kinds of fiducials are available in the market, like bone fiducials, like bone screws, and skull implanted fiducials. But they are not used these days because they are invasive. So the simple to use are adhesive markers like this. It's so simple. It's a fiber material. You can adhere it to the skull, to the scalp anywhere. And another is without the fiducials, where you can use cranial markers like tragus or canthus, but usually they are difficult to locate. Once you drape the patient, it's difficult to locate. These are the important steps of neuronavigation system. First is obtaining preoperative images in the form of any images, CT scan, MRI, MRI, DTI, anything. And next is registration of the patient and correlate it with the images. Third is intraoperative localization. Fourth is intraoperative control. Fifth is obtaining intraoperative images and fusion with preoperative ones. This is usually must be done during the functional surgery. And finally is visualization and surgery. So this is the technical details of the procedure, how you start in the display. So it comes to what procedure you want to do, like tumor resection, sound placement, or spine pedicle screw, whatever procedure you want, you have to start with this selection. See there in the right side, that is, you see the optical eyes, means that is optical camera, and another is that's a electromagnetic. So what kind of navigation system you are using? This is and then you obtain the preoperative images of the patient. Most important step in the neuronavigation is registration. If there is error during the registration process, you will have difficulties. Even you will not able to use the navigation system during the surgery. So it has to be very precise and concise. There are two types of registration process. One is when you apply the fiducials in the scalp, and by touching those fiducials, you register the patient. And another is, usually this is done in optical type of navigation. But if it is electromagnetic, then electromagnetic, they are not wireless. They come with some attachment. It has to be attached with a magnetic emitter, near to magnetic emitter. But but the optical is, it's wireless. Wireless because it reads infrared coming from the cameras. So these are called glians. They are usually disposable, but we use in many cases. Just clean it and you use it. So in trace type of registration, uh, fiducials are almost not used or very less, and it's very quick. It's less than a minute. So no extra consumable, no extra probe required. This is the setup of your operating room. On the left side, the monitor. Opposite to your is the display where you have to look. And if you are using electromagnetic system, then that a magnetic emitter has to be placed close to the head of the patient. Or if you are doing spinal surgery, it comes flat type of magnetic emitter, which you put below the in the table. Next step is instrument verification. You have to verify the instrument what you are using. You can verify any instrument you want. This is how the registration process with touch method starts. Computer will show you 3 points, known anatomical landmarks, like first is tip of the nose, and you have to put your pointer, the tip of the nose, like number 2 in the neck zone, number 3 like one of the anywhere like orbital ridge or tragus, anywhere. So once this process is done accurately, you start registration process. This is how the registration process starts. You start by touching, and if you don't touch the scalp in between the registration, the chances of having error is always high. So try always touch adequately with the scalp. After the completion of the registration system, this is what you see in the monitor. You see in the real time. Wherever you put the tip of the probe, you will clearly see the margins, you see the lesion, and then you plan accordingly. You can see edges, anterior, posterior, trajectory, whatever functional MRI you see, tracked, anything, and you continue your surgery. So this process has to be repeated again after you drape the patient. So because of this, everything precisely, now you can plan your size of your craniotomy and the trajectory. And pre-op data is collected in either CD-ROM or in external hard drive. So this is the so-called patient's reference frame. This is very important. It has to be kept close to the patient's head or spine. If you are doing electromagnetic emitter, that has to be kept close to the head or close to the spine. This is very important because it comes with See, multiple glians, and this is what infrared picks up, and from this, the images, it goes to the your pointer, and this is how you navigate the lesion. So once the registration process is completed, registration system can display the location. So commonly display arrangements include must be in all three sections: coronal, axial, and sagittal. You have to look all these three images. Like in one of this case, you can see the lesion and boundaries of the lesion in all the section of the brain. And this is finally extent of the evaluation of your surgery. Device tracking. There are two types of device tracking. One is optical, and another is electromagnetic system. So it refers to use of the navigation system localizing technology to track an instrument or probe in space relative to the patient. What happens in optical tracking system is here. So it uses camera as the localizer, and the camera has two lenses so that it can see the positions of tracked devices in 3-dimensional. So it is based on the theory of trigonometry. It has active tracking system and passive tracking system. In active tracking system, camera detects IR light emitted by LEDs on the system, while in passive tracking, the camera detects IR light reflected by the spheres on the instrument. This is how a trigone is made. But the very important step in optical system is line of sight. It has to be very straightforward, clear to your instrument, or if you are using CT scan, it has to, it must see your CT scan sensors. This is the setup of using optical tracking system. And there you see the lens, the cameras. So these two camera, these eyes must see all 4 sensors in the CT scan machine and the instrument you are using. Another is electromagnetic tracking system. It is based on the generation of a magnetic field and the presence of coils in the tracking devices. They are never wires. They comes with the wire. So it has magnetic coils in the pointer. This is how it works. And it's a very simple, see, first it was stereotactic frame-based system, and then frameless system. Now it is electromagnetic, which is I think it is very simple to use, because you don't need to put patient in the headrest. You can move the head at any time. If once you are doing the surgery with the use of optical navigation system, head is fixed, you cannot move it, and putting the 3-pin is always troublesome for the patients, especially pediatric population. Advantage of this technique includes its abilities to provide tracking without the need of maintain of free line, and then you don't need free line. If you use optical one, sometimes, many times, your own head will obstruct you from from displaying the navigations. This is electromagnetic system. This system is attached in the table, and you see that is the black thing, which is close to the head, is the electromagnetic. This is called emitter. In the head, it comes in this shape, while you use in the spine, it is flat. It is like a X-ray cartridge. You can put it beneath the body of the patient. So the advantages of electromagnetic navigation systems are, you can use it in traumatic head injury patients who had like multiple skull fracture. You cannot put the 3 pins. Or if you are doing awake craniotomies, or it is very good option, another option for pediatric populations. And there are other many advantages as well. No line of sight issue, simple plug and play like. Yeah. This is one of the example of pituitary macroadenoma. case. So this is a patient is getting intubated, and you see the arrangement in the operating theater. And so you see there is a tram on the base of the table. This table is very special. This is made up of the carbon fiber, so that it is radiolucent during the surgery. And another beautiful thing about this table is you can rotate this table in 360 degree. So that like if you are doing cranial surgery, usually in this position you keep the patients. If you are doing spinal surgery, it has to be perpendicular. And after anesthesia, you take the intraop imaging if you are planning. But if you are planning to take intraoperative imaging, it has to be with attachment of this patient reference frame. And this is intraop imaging of that pituitary case. You can see this, it was a case of pituitary with a little bit dense area, probably case of apoplexy. And this is a video I'll not show because it's long. So, and all the instruments, they come unsterile and sterile. So after you drape the patients, you again use everything you use in sterile form, definitely. So this is the intraop after excision of the tumor. We had doubt whether it is blood or residual. And then after waiting for a few minutes and washing, finally we did second time intraop CT scan, and it was almost a complete excision of the tumor. So the major advantage of the use of neuronavigation system is you exactly know if the tumor is left or you have excised it completely. These are the few cases of biopsies, right? Like in this case, see, it is so close to the ventricle. So I'm reaching the tumor without piercing the ventricle can be achieved very safely. Another case of this thalamic tumor. All these cases are easily done by the residents. They do it because it's so simple. I mean, you display the images, you plan accordingly, and if you know, definitely you have to know the real anatomy of the brain. This is another case. This is probably callosal lesion, and this is supracellular lesion, and this is another left thalamic lesion, and this is a case of posterior fossa tumor. As I told, in case of other surgeries, you may not need to use the fiducials. But if you are doing posterior fossa tumor, or if you are doing in prone position, as there is not many anatomical landmarks, so it is always advised to do it with the use of fiducials. You use optical navigation system. The beauty of the navigation system is, like it was a case of cerebellar lesion, and which was almost iso intense. And then the technicians, he isolated this tumor in different color, so that you can clearly isolate from the normal tissue. Clinical application, it is written there is clinical applications like small intracranial lesions, skull-based surgery, intracerebral biopsies, intracranial endoscopic. Yeah, even during the endoscopic third ventriculostomy, and people are using navigation system. And the study had shown that ETB, by using navigation system, injuries are less compared to other method, and definitely widely used in functional neurosurgery. So these are the clinical applications written in the textbooks or in the many literatures. I think if the time will come when all the procedures, including traumatic extradural hematoma evacuation, all other procedures will be done with the use of navigation systems. Why we are not using this system? It's because of because it's a new, and it's because of expensive. As the use increases, the cost will definitely come down, and we'll use it in all the cases. So it is useful in providing orientation to the surgeon with sufficient application accuracy. It facilitates a precise planning of craniotomy. It defines the tumor margins and the limits of extension, useful in localizing encased and displaced vascular structures. You can see tumor extension and position of the osseous landmarks. They have drawback. See, this is so big. This is long, even longer. This is even longer. So the probe is bulky. The view of the surgeons, and while you are using it during the surgery, you have to again look at the monitor. So chances of injury to the brain is there. It's like it's like during the ICG, use of ICG. You have to look at the monitor, and you might sometimes injure the vessels or tissues. So the requirement of an uninterrupted line of sight between the lead and the camera, and patient head cannot be moved if we are using optical system. But if we are using a magnetic system, you can easily you can tilt the head. Another drawback is if you are using, usually we use microscope. So between the scope and the surgery site, distance are very less. So it distorts. It again distorts many times. There are conditions when even surgery using navigation system were failed, and like this another tiny lesion. So usually after we use less stereotactic compared to frameless other navigation system is frame based, but as the results are almost similar. But in such cases where we don't have positive results, we use frame based surgeries, and see the pitfalls of the thing is you have to put it under the local anesthesia. You send the patient in CT scan machine with this head frame, which is troublesome, difficult for the patients. And this is how you plan accordingly. And another challenge is for anesthesiologists with this frame putting the endotracheal tube. They need special dedication. And this is another example of binary region tumor biopsy. And the probe are so fine, so that even in the post-op images, you don't see any scarring. And one of the common complications of these procedures during the biopsies are intracerebral hematomas. But luckily, in our series, till now we have not seen any such complications. So that's all about cranial navigation. Now I'll talk a little bit about the spinal navigation. So the spinal navigation was brought in use almost a decade after the cranial navigation. It came only after frameless surgery for frameless cranial navigation system. So the history is not old. So these are the conventional intraoperative spinal navigation as we discussed for cranial, like direct visualization. Surgeon's knowledge is the most important navigation system, no doubt, experience and judgment. Plain X-ray, see still many centers, they operate by using only plain X-rays, but the drawback is it gives only one plain image, and then you have to wait for the image to come, and then you start the surgery. CM is widely used, even we use, but the limitations of CM is you'll have only static images, and it has a lot of radiation. Every time you bring the machine, back the machine, and time taking is also very long compared to others. And different other types are like SSCP, MEP, and ETC monitoring. And to again overcome these problems, image guided surgery in the spine were also applied. And new spine navigation, to use of navigation system in the spine is not as straightforward as in the cranial surgery, because there are a lot of movement in the spine surgeries, starting from the positioning, and so fiducials, they are easily violated. So for minimal invasive MIS surgeries, you must need some kind of fiducials, like which are made of the carbon, polymer, or gold. You have to use it. And there are different, there comes different types like cylindrical or coiled. And based on this, only you can proceed for the surgery. So the challenges are, it's the use of percutaneous fiducial markers are difficulty, and intrametallic fiducial markers, and it will show a lot of metal artifact. So to come over those problems, Foley and Smith reported to use the anatomic landmarks again in the spine, like spinous process or lamina or pedicle or pars, that as a registration method. This is what we are doing. So you see, this is the dynamic reference array. This is called dynamic reference array, which is clamped in one of the spine. And this is how registration starts. And the picture is displayed there, all three sections. And this is how you register. You put the tip in wherever you want, at least three anatomical site, like a spinous process or pedicle or pars, at least three places, and you confirm the trajectory accordingly. This is intraoperative CT based. I mean, in all cases of, like, not like in the cranial cases where you obtain the pre-op images, put it in the monitor, and you operate. For the spine surgery, you have to do intraoperative CT scan, and only real-time surgery can be proceeded. So this is the patient is getting a CT scan, the required area. And you see, this is the localizer. And also you can see the dynamic reference array, which is attached into the one of the spinous process. And after opening this, after doing the subperiosteal dissection, after exposing the bony landmarks, you send the patient for imaging, intraoperative imaging. These are the picture, how displayed in the, and now prior to surgery, you know size of the pedicle, and you plan trajectory accordingly. You can see the vital structures around your surgical site, and exactly, very accurately, you can calculate the size of the screws, diameter of the screws, and trajectory of the screws. Any instrument you can navigate, any size. You see, there are multiple holes. It depends upon the size of the instrument. So according to the diameter, you can navigate any of your instruments. Even in one case of the tumor, which was, I mean, very not clear, even in the MRI, it was less contrast optic. So we thought intra-op navigation might help, and actually it helped to not only the exact localize the tumor, and for the total excision of the surgery. So for navigation system, all the images has to be acquired in a special format, like CT scan should be less than 1 millimeter thick. This is in the spine surgery, when you use electromagnetic field, and that is the magnetic emitter, which is placed below the chest. So the advantages of spinal navigation are accurate. You can accurate plan of incision and trajectory, safe placement of implants, especially in anatomical critical areas, Guidance for posterior incision and approach for minimal invasive implant placement. This is very good for MIS in the spine. And many studies have shown that X-ray exposure is much less than what in the conventional methods. And multiple treatable indications like cervical and high thoracic dorsal instrumentations to routine lower lumbar surgery, complex deformity surgery, tumor treatment, and surgery planning. So both pre and intraoperative images can be registered for navigation. So is the navigation in spine surgery necessary? If you, many study has shown that without navigation, chances of cortical breach is almost 20 to 30%. But with the use of navigation system, the chances of misplacement is less than 2%. So it allows 3D image in the real time, and it has definitely less complications because you can see the vital surrounding structures, reduces reoperation due to malposition, and it is very good to use in the small pedicles and in case of altered anatomy and deformity cases. And as I told you already, that radiation is less compared to the other conventional type of imaging modalities. There are technical pitfalls of navigation system in the spine cases, like in obese patient, the ray is hardly difficult to penetrate, so chances of error are very high. And definitely there is surgical learning curve. I tell you, use of navigation will add you extra 1.5, 2 hours, sometimes 3, 4 hours. So this is frustrating for surgeon. But if you look at the patient safety at the end, you know, so this is very difficult learning curves, and you need special carbon fiber surgical table, and you have to drape many times during the surgery because you take images 2 times, and registration process is also not so straightforward in the spine. And there are certain considerations depends upon the level of the spine, like cervical spine, which is in case of hyperlordoric spine where the surgical field is less, then you need to fix the in the headrest. You must do it. In case of thoracic spine or thoracolumbar spine, see, this is another good for thoracic spine, thoracolumbar spine, compared to this fluoroscopy or pluroscopy, because it is inside the thoracic case and images, you don't see so clearly. But in neuronavigation, it is very clear. The only drawback is you have to keep the patient apnea during this intra-op imaging in the apnea state. In the lumbar spine and lumbosacral spine, this patient reference area has to be kept in the iliac crest. To conclude about the spinal navigation, use of navigation in spine surgery has improved the safety of spinal instrumentation. Improvement in navigation technology will continue to expand its application in spine surgery. And this technology, however, should not substitute for a thorough knowledge of spinal anatomy and traditional method of instrumentation. Definitely, after you know all these, it will be much beneficial. But without knowing, navigation will never help you. So in about 1 year, we have used navigation in around 65 cases. We use navigation system in 100% cases of tumor excision because of it is very helpful. It is really very helpful for pituitary. And chance you clearly see where is the carotid or optic chiasm, and you can nicely see the bony sphenoid anatomy, presence of any septations. It is very clearly seen, and we use in sometimes planning for tumor biopsy, like one case catheter placement, in cyst aspiration, and in pedicle screw placement. So despite use of navigation system, we had inaccuracy in 2 cases. The histopathology were negative. So to conclude, neurosurgery will never be the same after the introduction of neuronavigation. The possibilities for the application of neuronavigation to contemporary neurosurgery are practically unlimited, with the potential to supply better guidance, orientation, and localization, and hence a higher confidence level for the surgeon and improve outcome for the patient. If you have these instruments during the surgery, definitely your confidence level is very high. This is not the end of the navigation. So what is the future of navigation is future will be cost effective, intuitive, ergonomic, user-friendly, accurate and precise with possibilities for not only structure and physiological, but also functional and biochemical multimodal image fusion and intraoperative real-time update of image data integrated with robots. Thank you very much.
Thank you, Dr. Rajiv. It was a wonderful presentation.
Thank you, sir.
And very much deserve you. This topic was, somebody should have talked about this way long time before. And so let me, before I ask few questions and take up questions, let me thank Aditya again. Aditya, you are there?
Yeah, hi,
Dr.
and Rajiv.
Thank you very much for
excellent
joining this conference. Your presence is very valuable. Our politicians are fighting in the borders, and now, science is beyond politics. So we are sitting together and sharing knowledge, and that's science. We are beyond borders, beyond politics. So it's so nice to have you in this forum today, Dr. Aditya.
No, it's my
Thank you
pleasure.
very much.
It's my pleasure, and I wanted to thank Rajiv for an excellent and very exhaustive presentation.
Thank you, sir.
I learned many things afresh from his presentation, and I think it's been a very comprehensive, very informative presentation.
Thank you, sir.
So a few of the points that I want to mention from my side is that about 25 hospitals in Nepal is having a full-time neurosurgical departments, and probably only 5 have neuronavigation system. So there's a severe limitation of use of neuronavigation in our country just because it's a formidably expensive. And there are a lot of equipment that is coming from Latin America where the cost is pretty low. And I remember a gentleman, engineer who came from India.
Yes.
And he wanted to develop a system, but then nobody supported him there. So we worked with him for about 2 years. And then he developed a very simple system, neuronavigation system, which we are using, and which is almost 1/6 of the cost. And it is they are marketing it from India, yes. And it is good enough, So it takes you where you want to go. And as you have rightly said that, when you work on posterior fossa, there's a severe limitation of any navigation system and potentials that you have put, especially on posterior fossa, because there's not much of landmarks. And sometimes we use navigation stereotactic combined, When you want to reach the definitive target, then we will use stereotaxy. And then once we reach there, then we use the navigation system, sometime very rarely. But, stereotactic system has got, the precision is in millimeter. And whereas navigation system, the precision is not to that extent. So, you cannot put DBS or you cannot make lesions with navigation system. And as you know, the most important and the limiting factor in navigation system is brain shift, which nobody has got an answer till now. But in your setup, I can see that you have got an O arm, so you can, in between, you can correct your position and then, re-navigate yourself to the correct position. And the best use of it would be, there will be no brain shift when you are working on a skull base, especially on skull base, because the brain shift doesn't work there. So overall, this was a very insightful talk, and thank you very much. And let's take some questions from the audience.
Thank you.
Namaste, Resa bolira.
Hi, Resa.
I have one question. Most of the images that you showed for navigation were CT based, even for thalamic tumor biopsy. I would suggest MRI based pictures rather than CT based. So, what is your comment about it?
Very straightforward answer is we have intra-op CT scan. So we frequently use CT scan. Yeah, definitely. Otherwise, MRI has better result compared to CT scan. But as we have intra-op CT scan, we have to rely on intra-op CT scan.
You can fuse your MRI images with the CT scan. That would be much more appropriate and accurate.
See, for such lesions, where only to take biopsy, you don't need. I don't think you must need to fuse it. Definitely, if you are doing some functional surgery, you have to do it, and we have to do it.
Okay.
Hello.
Yes, Pawan sir. Namaste.
Namaste. Thank you, Rajiv, for a very wonderful presentations. I really, because I had an opportunity to have a observation of the imaging 23 years back, and I see the technology has entirely advanced, and which is really now, it is not understandable to me currently, but anyhow, your presentations made me to understand it. And I would like to know a few things that, do you need any consumables during the surgery, which you use, throw, and then you again need patient to buy?
Not actually no. Till now, no. Yeah, you use. I mean, as I told that these are the glands. They are actually disposable, but we use it. We are still using it.
So patients do not need any extra cost for that.
Nothing. 0 rupees for the patient.
And how much it is helpful as access is all right, and direction is or trajectory is all right, but is there help of this in the extent of the excision?
Yeah, definitely, yes, sir. It's to see the extent of the lesion, and or like the about the brain shift, which is one of the problem in navigation. So it can be missed, but if you are using intra-op imaging system, then you clearly see how much you have resected or how much is left there. Only navigation, I mean, only pre-op, based on the only pre-op image, you can miss the lesion. But if you use intra-op CT scan or MRI, chances are almost less.
Thank you.
Thank you, sir.
Dr.
It's me, Dr. Prakash Paudel. It's a nice presentation.
Thank you.
So, which company you are using? Is the Medtronics or Brain Lab?
Fortunately, we have both Brain Lab and Medtronics.
Rajadai.
Yeah, we have both Brain Lab and Medtronics.
So do you suggest which company do you feel more comfortable with? Or any suggestions with respect to the choice of the company? Since you are using both the companies?
I think both are the same, still the same. I don't see any differences in the technique.
Okay.
Both are same. You can buy anyone.
Okay.
Dr.
Thank
Rajiv,
you.
so that was a very good presentation. Thank you for that. My query to you is, like, what has been your experience while using navigation with the fusion of functional MRI or DTI images?
I never spoke of these functional cases in our institute because we are not able to start it yet.
Okay. So may I request
Yeah,
Dr.
can I
Aditya
say
to give
something
his,
on that?
Yes,
yeah,
sir.
please, sir.
Sometime we are using a 3D CT angio on our aneurysm cases. We incorporate 3D angio, CT angio, to the neuronavigation system to localize, when the aneurysm is, not well localized. Sometimes you can use that, but not with GTI. Aditya, have you used GTI with navigation?
Yes, so we have used DTI with navigation. Now,
Yeah.
what can be done is, in fact, the system which we have, and I believe Rajiv, you have the similar system. The system comes with an optical DTI capability of its own. So if you have the correct raw MRI fed into the system itself can do the DTI processing.
Okay.
So if you use that function, then you can have the tractography, and you can later on use the tractography information and draw out the tract as an object. So if you're navigating for a glioma, for example, which is very close to the motor tracts, the motor tract can be defined as an object. And while you're working in, of course, there will be brain shift, but it can give you a rough idea of where you are in relation to the motor tracts. So that is definitely doable. But of course, to set up that, you need some technical support from your vendor and your radiology so that they are giving you the correct raw information.
Thank you.
So a couple of
Thank you,
comments
sir.
which I wanted to make here, and of course, this is more for the benefit of residents and younger people, is that, navigation is an image-guided surgery. So the accuracy of the navigation depends on the slice thickness and the resolution of your imaging. So I think one of the basic things that Rajiv has showed us very nicely is that the navigation protocol for imaging has to be set up very carefully so that your slice thickness, which you can reconstruct, should be not more than 1 millimeter thick. If you're using very thick slices, then accordingly, geometrically, your accuracy is going to go down. And the other very, very grave error which you can land up with is if the right-left orientation from your radiology to your navigation system is off. So once when we were setting up our navigation system around 4.5 years ago in Artemis, in one of the cases, we landed up with the probe showing the tumor on the opposite side. Then we realized somebody had gone into the basic, the attributes of the navigation system, and they had changed the orientation of the images. So sometimes we blindly start using these technology, and the basics have to be very, very carefully taken into account to preserve grave errors from happening. The other thing which I would like to mention is that you see, when as navigation becomes cheaper and more institutions get access to navigation, we should take care not to lose our basic skills in working without navigation. So for example, a surface lesion, to be able to make a small incision without using navigation, it is a skill that all of us have learned during our residency. And the important thing is to keep that skill alive, because you never know when this high technology piece of equipment may crash on you, and you don't want to be suddenly lost in those kind of situations.
Absolutely, Dr. Aditya. Well said. Once you start using navigation, your orientation gets. You don't need to use your orientation. These days, you don't remember any telephone number.
Absolutely.
In the past, you remember all telephone numbers. Now, it's all there. So that is absolutely correct. And one of the things that I want to again stress what Aditya has said is that in our institute, we tell the radiographer that you take all CT, all MRI, at least one image, whether it's a T2 or T1, on navigation system. So that is 1 millimeter thickness without gap, so volumetric scan, so that you can always feed it. And because you never know when you are going to use that navigation system. And if you don't take it in the first place, then you have to take it again. So this is a system that we have developed, and at least in all cases, a CT scan, there's no problem because most of the time it's a 1 millimeter cuts. So it's not an issue. But in MRI, either T2, most of the time, T2 volumetrics can at least one, which is can be used for stereotactic or navigation, is taken, so whenever you need, you can use that image. And one of the things I really loved about Rajiv's expression is he said that when he do surgery, he take the image again, and then he fuse that in the previous image and compare how he had done it, And that is absolutely the way to go. And that is a very, very important thing that, it will teach you, in every case, how you have done. So you can fuse the image, latest image, post-op image and pre-op image, fuse it. That's what you are telling. And I think that's a wonderful idea. And sometime we are using that as well. Yeah, thank you.
Sir, that's very well said. Actually, whenever putting a DBS system, a DBS electrode, it's always better an idea to fuse the post and pre-op and see what all we have done. That's a very good comment. So, do we have any other questions coming?
So I'd like to make a comment here that Rajiv has showed some excellent cases of frameless biopsy, and personally, what I would like to say is that I would not like to do a frameless biopsy of a lesion which is less than 1 centimeter in diameter. For that, maybe I will go to a frame-based biopsy. Because if you look at the physics studies which had compared all these navigation systems, the total end-to-end accuracy of these systems is in the region of 4 millimeters. So if you are 4 millimeters to one side in a lesion that is 1 centimeter in diameter, the chances of a geographic miss are substantially high.
Yeah, absolutely correct. And especially when it's a lesion in the depth, then it's always better to go for stereotaxy rather than, on the surface, stereotaxy is not of use. On the surface, it's horrible. And the jet becomes so long that you don't even can operate, So in the depth, absolutely, I agree with Aditya that most of the time the, error is so high that it's better to go for. And sometimes we have combined actually navigation and stereotaxy we have combined sometime. Yeah.
So I think the only exception I would say is there are studies which show that if you use skull implanted fiducials and you use at least 4 fiducials which are implanted in the skull, then you can achieve an accuracy of close to 1 to 1.5 millimeters. Barring that special circumstance, one should assume that the end-to-end accuracy will be something like 4 millimeters.
Yeah. But when you use screw type potentials, then the cost becomes higher, because these are disposables.
And it defeats the non-invasive nature of what you want to do, right? So if you're poking in 4
Absolutely.
places and then making a smaller incision, patient may not be very happy with that approach.
Absolutely. So any more questions, Amit?
Yeah, so thank you, sir. Thank you, Dr. Aditya. Thank you, Dr. Sir, for auditing this session, and it was a very interactive one. So if we do not have any other further questions coming, then may I request all the participants to please log on to menti.com and we will have a feedback session. So may I request Dr. Rajiv, thank you for your presentation once again, and may I request you to please stop sharing and allow me to share the questions.